situation you have to recognize is it is much easier to remove the nucleus while it's remain into the anterior in the capsular bag or anterior to the capsule, because the subsequent instrumentation may end up in the drop of the nucleus. So these are the few steps that anybody can do, but for these steps you may have a skill of going through the pars plana approach. So you can insert the trocar cannula and inject the viscoelastic behind the ruptured capsule like this. So in practically it looks very easy that you eject it behind it, but it's not easy when you are having this problem, because most of the nucleus drops happens when the patient have a small rhexis. When you have a small rhexis, it's very difficult to bring the nucleus into the anterior chamber or anterior to the anterior capsule. So it's not easy at that time. Then you keep on pushing and viscoelastic and bring the nucleus chunks into the anterior chamber. Similar problems you may get the opening of the wound from the limbal or corneal wound. You may have a high pressure and gets the cornea edematous. So multiple things are happening at this time because the surgeon is exhausted and the patient is not behaving normally, even if he knows that he has a complication. So next step is here. Here I usually prefer, you see, if I get this pointer, no, it's not visible. So I will show. So the viscoelastics making the two chamber intact. This is the anterior chamber and vitreous cavity. So basically you are achieving the two chambers separately with the viscoelastic. So I will start from again this video, and here you will see. So surgeon did the same thing, and he is putting the viscoelastic, trying to separate the anterior chamber from the posterior segment. With the Simcoe cannula, he is extracting the peripheral cortical lens matter, but the posterior capsule rupture is extending with each and every step of the surgeon.
Kakan, 1 minute.
Sorry?
1 minute.
1 minute. So in this case here you can see that at the end, surgeons was kept on doing, and he is doing the vitrectomy through the limbal approach. The thing here is with the viscoelastic, he got some vitreous into the anterior chamber, but he cut it at the end. He has a good filled anterior chamber, and he is inserting the foldable intraocular lens in the bag implantation in this case. So this is basically is how you approach to the limbal incision. Here is how you approach the, just 1 second. So through the pars plana. So this is a 20-second video. The thing here is the patient is under topical anesthesia. It's not easy to insert the trocars. How you will augment? Patient knows that I am having surgery. The anterior segment knows that he is in trouble. So things are not easy, and getting the VR surgeon at the time and having the trocar inside the eye with the drop nucleus with the posterior capsule rupture for the anterior vitrectomy, it's not easy. So here the surgeon was in difficult condition. He did anterior vitrectomy. His whole nucleus is lying into the mid-vitreous cavity. The other surgeon just accompanied him, and he just put the triamcinolone to confirm whether there is a vitreous or not. So he is doing good and removing all the vitreous from the anterior chamber.
I'm sorry, we'll have to stop here. Any concluding remark?
Sorry?
Any concluding remark? We'll have to stop here for the sake of time. Any concluding remark?
Yes, concluding remarks is that it's not always easy to put the trocar when you are having a posterior capsule rupture, and it's very easy to say that you can go through the pars plana, but think about the situation when you have a posterior capsule rupture with the drop nucleus and patient is under the topical anesthesia. It's not easy, and patient knows that something bad has happened, and surgeon knows that something is going to bad and worse. So limbal approach is not as bad if you manage the anterior hyaloid with the viscoelastic abruptly and promptly, sparing that you have a viscot in the anterior chamber. Then it's bit safe. I'm not good for anterior chamber maintainer. I rather will use the direct flow from the Simcoe cannula or other cannula, because anterior chamber maintainer also damages with the push and pull. Thank you so much for kind attention. If you will have question, I am here after the session too.
You can come and sit next to us. Thank you, Dr. Devek. Kakan, come and sit here. We can ask you a question until Dr. Habib sets up. And Carson, I think you can follow Dr. Habib. We're trying to just group the cases together. So for the anti-segment surgeon, just in a quick one, pars plana or limbal, which one you would suggest?
For anterior segment surgeon, if he recognizes the complication quickly and he doesn't remove his probe and fills the eye with the dispersive visco to keep the anterior hyaloid intact,
Yes,
then
that's
the limbal approach can be done.
All right, thank you so much. Okay,
Sure, I'm
Dr.
ready.
Habib is speaking about intraocular perforation during local anesthesia.
Hello, everyone. I would like to thank the committee for this invitation, and I would like to share with you our experience with intraocular perforation during local anesthesia. The needle perforation has been important with incidence up to 1.3%. The risk factors are the retrobulbar anesthesia, high axial myopia and posterior staphyloma of the eye, uncooperative patient, and multiple injection attempts. So the complications usually are vitreous hemorrhage, which is the most common, retinal breaks, RD, endophthalmitis, and to a lesser extent, vascular occlusion and macular holes. So one to suspect that there has been a needle perforation in this eye, first with the anesthesiologist, if he finds that there is hypotony with the eye or a sharp increase in the IOP if he injected into the eye. Also, there's a part on you if you find there's loss of red reflex. The red reflex is a bit dark red. Anything off about the case, you should be suspecting and putting the perforation possibility in your head. Also the subluxation of the lens, we have seen some of the cases like that, which wasn't present before. So there are patterns of reactions of doctors to these kind of situations. The not so wise doctor, those make the wise decision, not so wise, that to wait and see after the diagnosing of hemorrhage. For example, this case has been waiting and seeing for 2 months. As you can see, there is organized vitreous hemorrhage, and you cannot see the retina. It was diagnosed as RD, but actually it was a dense vitreous hemorrhage with posterior hyaloid thickened. As you can see here, that the place of perforation of the injury is at the posterior pole and near the disc. Usually in this kind of cases, an epiretinal membrane forms and it is usually thick. In this kind of cases, I just peel the extensions of the membrane and collect it over the site of entry. And I don't prefer to remove the epiretinal membrane from over the site of entry in case there is a break or something more. So I just pull the extensions of the membrane from over the retina or the macula and just shave over the site of entry. Also, if this is an old membrane and it is extending over the macula, I usually do an eye lamp peeling, not only for the eye lamp peeling, but to ensure that the PVR over the macula is removed. The other pattern is the not so forward doctor. Those convince the patient that the healing process, that it's a healing process, and they just give anti-inflammatory drugs until the patient is fed up and goes to another doctor. This was referred to me by another doctor who was diagnosing endophthalmitis. This patient had hypopenia, which with antibiotics and anti-inflammatories improved, but as you can see, there is vitreous hemorrhage and actually severe inflammation and maybe low-grade infection. This has been there for 2 weeks. He did the operation 2 weeks before. And after removing the hemorrhage, I usually take good care to do the PVD very slowly, because the site of injection or the site of injury, at this site, the PVD cannot be done, and the vitreous should not be pulled over. So I just, as the other case, trim around it and over it, and just do a barrage. And this case was put on gas, and it went well, alhamdulillah. And this is the best pattern, the not so alone doctor. These kind of doctors, they have a VR specialist at the team, and they don't hesitate to refer immediately to the VR specialist. This is it's the first day post-operative. This is the day after the incident happened. And as you can see, there's fresh vitreous hemorrhage and multiple injury sites on the retina, and it's usually there's an entry site peripheral and multiple sites in the posterior pole. Here you can see 3 breaks and subretinal hemorrhage. But don't forget to check the periphery, as there's usually an entry site on the peripheral retina. This case was managed also with the laser barrage around the brakes, but here I elected to put silicone because the retinal brakes had ragged edges, so I decided to put silicone, and it went fine, alhamdulillah. So in our experience, our best results were achieved with early intervention, attached retina, spared macula, and if we can put gas tamponade, things go well. But if we put silicone, we stay for more than 2 months. Usually there is an epiretinal membrane that forms, and it's usually thick. So you should expect this outcome. So what to do if you expect a perforation? Please don't proceed with surgery. If you find anything suspicious, stop with the surgery, don't proceed, and examine the fundus thoroughly. If a break is found and there's a clear media, you should laser. If vitreous hemorrhage is present, refer to a VR surgeon, and in my opinion, immediate intervention is my choice. If a retinal detachment is present, refer to a VR specialist also for the postprandial vitrectomy. So in conclusion, needle perforation can happen even with the best hands. Be mindful of the possibility. You should have a look on the red reflex before starting the surgery. If there's anything off, don't start it, because if you start it, it's your responsibility. So, and if a needle perforation occurs, immediately deal with it or refer to a VR specialist. Thank you.
Thank you so much. Can you come and sit for discussion as Dr. Karsten connect? Yes. Can we have help here, please? Can we have help connecting?